Good morning, everyone. I'm Brad Rovin from Ohio State University in Columbus, Ohio, and it's my pleasure to be here for the Brazilian Nephrology Conference. I wish I could be there in person, of course, but I guess this will have to do. These are my conflicts, but they won't really apply in this particular talk. So today I'd like to go over some of the highlights of the new KDIGO Glomerular Nephritis guidelines that will be coming out this year. And different than the guidelines from 2012, I'd like to point out a couple things. Recommendations, which are based on randomized clinical placebo-controlled trials, are the strongest evidence we have, and you'll see that the number of recommendations is very limited because there are not a lot of good, strong randomized controlled trials. However, to make this guideline clinically useful, we have put in a number of practice points, and these are based on a variety of sources of evidence that are less rigorous than a randomized controlled trial, but can also be used to help us manage patients. These can be cohort trials, observational studies, and then when there's absolutely nothing, expert opinion is used. The other thing that's different about this year's guidelines as opposed to the past is that they will be printed but also be online through an application called Magic App. And the guidelines are meant to be a living document that can be updated in real time as new developments come forward. And as many of you know, there's a considerable number of trials in glomerular diseases now. Some of these are likely to be positive and will change the way we practice. So today, because of time constraints, I'm going to highlight points that I consider maybe worth changing practice or will imply changes in practice, a sort of potpourri of the guidelines. But if I fail to discuss your favorite glomerular disease, I'm sorry, we just can't go over everything. So I'd like to start with FSGS. I'm always going to have the work group listed on the side of the slide, and these are the folks who wrote this particular section of the guidelines. So one of the problems with focal segmental glomerulosclerosis is that it's often interpreted as a single disease, but of course it's not a disease. It's simply a pattern of glomerular injury. And that has really confounded clinical trials in the past by enrolling a heterogeneous population, and we've really made no particular advances in the therapy of FSGS. So if you'll follow this sort of chart with me, if you have focal segmental glomerulosclerosis lesions on light microscopy, we look for primary FSGS, and we're defining primary FSGS as focal sclerosis with diffuse foot process effacement on the electron micrograph and nephrotic syndrome. This is often of abrupt onset, and what's really important is this is the form of focal sclerosis that's most amenable to therapy. Genetic FSGS can be familial, syndromatic, or sporadic. And of course, these are often found in children with proteinuric kidney disease. Secondary FSGS can be due to a variety of etiologies, viral drug-induced, adaptive changes, which is something that we think about a lot. As you lose nephron mass and you have glomerular hyperfiltration, you can get lesions of focal sclerosis. Normally, with reduced nephron mass, or lesions due to hyperfiltration, we have segmental foot process effacement, we have proteinuria, but not the nephrotic syndrome. This type of FSGS is not generally amenable to immunosuppression per se, but the primary cause should be treated and rectified. For example, in the setting of obesity and FSGS, weight loss either through surgical means or through medical means would be an appropriate approach to therapy. And this leaves a whole population at the end of FSGS of undetermined cause. Most often, these patients have segmental foot process effacement on electron microscopy, proteinuria without nephrotic syndrome, but no evidence of a secondary cause. And this is very difficult, but we do not advise treating these patients with immunosuppression. This is the approach that we're using in the KDIGO, a patient with an FSGS lesion on biopsy. In the presence of nephrotic syndrome, defined as we usually define nephrotic syndrome, especially with diffuse foot process effacement. This patient likely has primary FSGS. We will recommend treatment with immunosuppression, and if the patients don't respond, consider genetic testing. In the absence of nephrotic syndrome, defined as we usually would define it, evaluate the patient for an underlying cause of to exclude secondary FSGS. Consider genetic screening where appropriate, especially based on age. We do not recommend starting immunosuppressive therapy. We do recommend supportive therapy, salt intake reduction, renin-angiotensin system blockade, and monitor proteinuria and serum albumin. Now, sometimes if you catch FSGS early, it's potential that it truly is a primary FSGS. So if there's a worsening of proteinuria and reduction in serum albumin, then think about that the patient may actually have primary disease and consider therapy. The recommendations we have are not different than the original KDIGO guidelines from 2012. High-dose oral corticosteroids be used as the first-line immunosuppressive treatment for primary FSGS, and for adults with corticosteroid-resistant FSGS, we recommend that a calcineurin inhibitor be given for at least 6 months, as opposed to continuing with high-dose corticosteroids. Now, I think this is really the most important point that I want to make. When the patient is resistant, we have no or very poor quality evidence for any alternative agent. And I realize that MMF, rituximab, ACTH have all been tried, but the bottom line is these have not been shown consistently to work well, and there's a lot of verbiage here, and it's somewhat complicated, but the bottom line is this sentence, patients should be referred to a specialized center with appropriate expertise. The translation of that is patients should be considered for clinical trials in FSGS, and there are clinical trials out there, and this is the only way we're going to actually move forward with understanding how to treat this disease. Okay, moving on now to immunoglobulin and complement-mediated diseases with an MPGN pattern of injury. So this was the old MPGN pattern. And like FSGS, membranoproliferative glomerular nephritis is not a single disease, but a pattern of glomerular injury. The etiology of a lot of these diseases that are often leading to the MPGN pattern is now not well understood, but better understood than it has been in the past. It often derives from glomerular deposition of immunoglobulins and complement, either as immune complexes, monoclonal immunoglobulins, or possibly in the setting of a dysregulated alternative complement pathway. So we suggest the old nomenclature of MPGN type 1, 2, which used to be dense deposit disease, and 3 should be abandoned. And part of the problem with understanding how to treat this process or this set of diseases is that the old trials were heterogeneous, and we really didn't get any good data out of these trials. Because of this, we have no high-quality randomized controlled trial data, so we have no recommendations in this chapter, just practice points at this time. This is a nice way to classify MPGN. We use immunofluorescence microscopy, and this will help you develop a differential diagnosis, which should define the direction of how you do the workup. So if you do a biopsy of a patient and it has an MPGN pattern, look at immunofluorescence for immunoglobulins plus or minus complement deposition. This would be considered immune complex or immunoglobulin mediated MPGN, and this can be seen in monoclonal gammopathies, autoimmune diseases, infections, and I've listed some at the bottom you can see. Now, there's a large category of what people used to call idiopathic MPGN, immune complex. And the reality is, at least in adult patients, this will be a very, very rare diagnosis. Most of the time, if you look hard enough, you will find one of these other etiologies that I'm showing here as possibly related to the MPGN pattern. So this should be really a diagnosis of exclusion based on a very good study of the patient. If the immunofluorescence shows dominance of complement components, we consider this complement-mediated MPGN, and this is C3 glomerulopathy or C4 glomerulopathy with C3 dense deposit disease or C3 glomerulonephritis or C4, same categories. And then finally, if the immunofluorescence is negative, this can be seen in the setting, for example, of antiphospholipid syndromes and TMAs, HUS, sickle cell anemia, for example. So there's several diagnostic pitfalls that we should talk about. These are all practice points. If there's no underlying etiology found for immune complex glomerulonephritis after an extensive workup, you should evaluate the patient for complement dysregulation. You should always think about ruling out an infection-associated glomerulonephritis or an post-infectious glomerulonephritis before assigning the diagnosis of C3 glomerulopathy. And then finally, patients should be evaluated for the presence of a monoclonal protein when they present for the first time with a C3 glomerulopathy at the age of 50 or older. It turns out immune complex GN is found and an infection and an autoimmune disease may not be obvious. Before declaring the process as idiopathic, it's prudent to exclude dysregulated alternative complement activation, as that could inform treatment. Complement can be dysregulated in immune complex GN, and classic C3 glomerulonephritis or C3G can masquerade as an immune complex GN if it was an infection that triggered the C3 glomerulopathy. Additionally, if a diagnosis of C3 glomerulopathy is being considered, it's prudent to exclude infection and monoclonal gammopathy. Again, this can inform treatment. Immunoglobulins may be masked, and the process can look like a C3 dominant lesion, but if the biopsy is pronase treated and then restained, sometimes the immunoglobulins will come out in an immune complex mediated GN. Additionally, monoclonal proteins in and of themselves may be able to activate the alternative complement pathway. Now, the management of immune complex GN, MPGN pattern, sort of broken up into degrees of severity. If the patients are doing pretty well, they don't have nephrotic proteinuria, a normal GFR, simply supportive therapy with RAS inhibition, lowering salt intake should be sufficient. For those patients who have nephrotic syndrome but normal renal function, we recommend or suggest trying a course of corticosteroids. As the disease worsens, so in other words, idiopathic immune complex GN, abnormal kidney function but not crescentic, and active urine sediment with or without nephrotic range proteinuria, corticosteroids plus perhaps a modest immunosuppressive such as MMF or azathioprine. For patients with rapidly progressive crescentic idiopathic immune complex GN, we do suggest or recommend treating with high-dose corticosteroids plus cyclophosphamide. If patients have advanced disease with a lot of scar on biopsy, it may be prudent to consider the risks and benefits of immunosuppressive therapy versus what can come back from the kidney. We've made two suggestions for C3 glomerulopathy. In the absence of a monoclonal gammopathy, C3G patients with moderate to severe disease could be initially treated with mycophenolate, and if this fails, consider eculizumab. However, if this fails, and it often can, patients who fail to respond to treatment approaches should be considered for clinical trials. And as many of you know, there have been at least 3 to 4 clinical trials looking at the complement-mediated diseases now. So we will be able, hopefully, to advance our understanding of how to treat these glomerulopathies. Okay, I want to turn to ANCA vasculitis. So the workup of a rapidly progressive GN, and as you know, an ANCA-Associated nephritis can be rapidly progressive. So the patient is often identified by a decline in kidney function. A urine analysis should be done. The patient shows blood or protein. If they don't, you should evaluate for a non-glomerular etiology of AKI. If they do, and the urine sediment is positive for glomerular hematuria, and then or pyuria without a urinary tract infection, and that's positive, consider a glomerular nephritis. Generally, you would send serologies to look for anti-GBM disease, lupus, ANCA vasculitis. Obviously, it's important to exclude infection. A kidney biopsy should be done. However, if the kidney biopsy will result in a delay in initiation of treatment, the biopsy can be put off, treatment should be started. Now, some of the initial therapies that one uses in most of these diseases, all of these diseases, would be corticosteroids in most patients, plasma exchange if anti-GBM glomerular nephritis is suspected, and if you don't want to immunosuppress the patient because infection is suspected, then intravenous immunoglobulin should be initiated. Specifically thinking about ANCA-associated nephritis now, we do recommend corticosteroids in combination with either cyclophosphamide or rituximab used as the initial treatment of new onset ANCA-associated vasculitis. And this is a change from the last KDIGO where we recommended cyclophosphamide. Rituximab is preferred under a number of conditions, certainly in relapsing disease, possibly in PR3 disease. And there's a couple of contraindications or issues where perhaps cyclophosphamide is preferred. If the patient has a very low baseline immunoglobulin level, that would be one consideration. Patients with hepatitis surface antigen positivity can have reactivation of disease and severe reactivation in the setting of rituximab, and so cyclophosphamide may be preferred. Especially important is the studies have not examined the use of rituximab in very severe glomerular nephritis with creatinine above 350 micromole per liter. Now, the combination of cyclophosphamide plus rituximab was studied in the Rituxavasc trial, and that is a possibility to use in this particular setting with severe glomerular nephritis at diagnosis. We also now recommend rituximab or azathioprine plus low-dose corticosteroids be used for maintenance after the induction regimen. And again, we've listed preferences for rituximab and preferences for azathioprine. I think most people would agree that rituximab is the preferred regimen now, unless of course you can't get access to rituximab or the patient has active or hepatitis surface antigen positivity. We did add a futility practice point. We suggest discontinuing immunosuppressive therapy after 3 months in patients who remain dialysis dependent and who do not have any extrarenal manifestations of the disease. Now, of course, ANCA vasculitis is a systemic disease, and if the patient has other than renal manifestations, you would continue immunosuppression. But if it only involves the kidney and they haven't improved or gotten off dialysis after 3 months of therapy, it may be better to stop the immunosuppression. They may not get better, and then consider the next move, which might be a kidney transplant, for example. This is a really controversial area, plasma exchange for ANCA vasculitis. Not a definitive answer, a practice point. We still suggest considering plasma exchange for patients requiring dialysis with a rapidly progressing serum creatinine and in patients with diffuse alveolar hemorrhage who are hypoxemic. As you all know, this has been very controversial. Plasma exchange was suggested by the very first study, MEPEX, to show a benefit in kidney outcomes for patients who presented with severe kidney insufficiency. A meta-analysis also suggested that there was a reduced incidence of end-stage kidney disease at 12 months. However, the PEXAVASC trial that was published earlier this year and looked at plasma exchange in patients with a GFR less than 50 or alveolar hemorrhage found that there was no delay in the time to end-stage kidney disease or death over a median follow-up of close to 3 years. There's caveats to this. A biopsy was not required, a kidney biopsy was not required for trial entry, so patients with poor kidney function and chronicity rather than activity could not be distinguished from patients with poor kidney function, inflammation, and no to little chronicity. And so some of those patients who actually had kidney parenchyma that was viable may have benefited. A subgroup analysis of the PEXAVASC study did suggest that patients with severe pulmonary hemorrhage could benefit from plasma exchange. It didn't quite reach statistical significance, but still, this gives us pause to not completely discount the possible utility of patients of PLEX in patients with ANCA-associated vasculitis. It should not be given to everyone. It should be considered for each patient individually, but it's possible that certain subgroups may actually benefit. Staying on the theme of rapidly progressive glomerular diseases, just a little bit of an update on anti-GBM disease. Again, if you suspect anti-GBM disease, initiate immunosuppression with cyclophosphamide, corticosteroids, and plasmapheresis in all patients, except those who are dialysis dependent at presentation and have 100% crescents in a good biopsy sample and do not have pulmonary hemorrhage. Now, there's a bunch of practice points that I think probably most of you know, but I've highlighted 2. No maintenance therapy of anti-GBM disease is necessary. So this is not generally a recurring relapsing disease like ANCA vasculitis and lupus nephritis. It's sort of a one-shot disease, and so prolonged maintenance therapy and keeping the patient immunosuppressed is not necessary. Additionally, and importantly, a large percentage of patients present with anti-GBM and ANCA double positivity. Those patients should be considered for treatment with maintenance therapy because if they have a significant vasculitic component, they are subject to relapse. Okay, and rounding off the systemic diseases, just a very quick update on lupus nephritis. This is the old KDIGO recommendation from 2012, and I want to contrast it with what we're doing or what we're recommending now, and this is sort of important. Their IV methylprednisolone was recommended to start with, followed by oral prednisone, or equivalent of prednisolone, up to 1 milligram per kilo per day, ideal body weight. So this is very high dose steroid. In 2020, we're actually recommending less IV methylprednisolone, generally around 1 gram, followed by oral prednisone, 0.6 to 1 milligram per kilo per day, with a fairly rapid taper down to 7.5 milligrams by the end of 3 months. I think this is important because more and more randomized controlled clinical trials are showing us that we can use fewer corticosteroids in patients with lupus nephritis and still have comparable results, which I think will benefit all of our patients because of all of the toxicities of the glucocorticoids, as you well know. Now, we also gave several choices of therapy in 2012. Intravenous high-dose cyclophosphamide, the so-called NIH regimen, oral cyclophosphamide, which again is about the equivalent of the NIH regimen over time, and then the Eurolupus or low-dose cyclophosphamide, which is 500 milligrams every 2 weeks for 6 doses or 3 months, or oral mycophenolate. In this year's KDIGO, we are now recommending, if you're going to use cyclophosphamide, use low-dose intravenous cyclophosphamide or the Eurolupus protocol, or mycophenolate 2 to 3 grams a day for 6 months. Now, finally, I want to get back to the steroid. The standard steroid dosing that we've sort of recommended, and everybody has their own unique tapering style, is listed here. But I do want to point out that there are data accumulating of a pretty reduced dose scheme, starting with 20 to 25 milligrams a day, and then decreasing it fairly quickly by month 3. And this is something to consider. And as you'll see, some of the newer trials are using fairly rapidly tapered corticosteroids. Okay, IgA nephropathy now. This is the scheme we recommend following. Proteinuria over a gram a day in IgA patients despite at least 3 months of optimized supportive care. Optimized supportive care would include good blood pressure management, maximum tolerated dose of renin-angiotensin-aldosterone system inhibition, lifestyle modification, and addressing cardiovascular risk. If the patient still has a gram of proteinuria at this point, consider enrollment in a clinical trial. If they have fairly impaired renal function, just continue supportive care. If they have a GFR that's preserved over 30 mil per minute per meter squared, consider toxicity risk stratification, but at the end, corticosteroids could be used if the risk-benefit ratio is acceptable. So the recommendations that were made in these guidelines is all patients with proteinuria 0.5 gram per 24-hour, irrespective of whether they have hypertension or not, should be treated with an ACE inhibitor or an angiotensin receptor blocker. The second recommendation, which has got 2B evidence, so that's less rigorous than the first recommendation, patients who remain at high risk for progressive chronic kidney disease, despite maximum supportive care, should be considered for a 6-month course of corticosteroids. And that's this arm of the schema. The important risk of treatment emergent toxicity should be discussed with the patients, especially those who have a impaired GFR below 50. Again, what I think is the most important part is what we don't support using. We all have patients that have IgA that don't do well, that have not responded to conservative therapy or corticosteroid therapy, and there's a whole wide range of immunosuppressives and other agents that have been used in patients with IgA nephropathy. Antiplatelet agents, anticoagulants, azathioprine, cyclophosphamide, fish oil. None of these are recommended because none of these have shown documented efficacy. And I know these are commonly tried by physicians who have IgA patients. Mycophenolate mofetil, there was one randomized controlled trial conducted in China with MMF and low-dose steroids that showed a positive result. So in this particular setting, one could consider MMF. In non-Chinese patients, there have been randomized controlled trials of MMF, and they've shown no efficacy. And finally, tonsillectomy is a therapy that's used in some parts of the world. Tonsillectomy should not be performed as a treatment for IgA in patients who are Caucasian. That may be indicated by some national guidelines. For example, in Japan, multiple studies have reported improved kidney survival and partial or complete remission of hematuria and proteinuria following tonsillectomy. So in these particular areas, there may be some local nuances to treating IgA nephropathy. Okay. To wrap up, let's talk about primary membranous nephropathy, because this is one of our glomerular diseases that has had considerable progress over the last decade. So one of the questions that comes up now fairly frequently is whether or not to biopsy the patient who is PLA2R positive, antibody positive, and proteinuric. And the KDIGO still thinks biopsy is necessary in such patients in the majority of cases. So if you have a PLA2R antibody test, the phospholipase A2 receptor antibody test that's negative, and a proteinuric patient, they should of course have a biopsy. If the test is positive and the patient has normal kidney function and there is no other indication of anything else going on, it's possible that they don't need a biopsy. And some folks do recommend no biopsy. However, if we are going to consider immunosuppression, if the patient has a rapidly unexplained deterioration of renal function, if the course is unusual in any way, if they have other serologic abnormalities, for example, anti-nuclear antibodies, or if they're unresponsive to immunosuppressive therapy or they have progressive decline in kidney function, it would be prudent to do a kidney biopsy. Now, treatment of primary membranous nephropathy is nicely outlined in the new KDIGO, and the idea is to risk stratify the patients in terms of risk for progressive kidney disease ending in loss of kidney function. And the recommendation is for patients with membranous and at least one risk factor for disease progression, rituximab or cyclophosphamide and steroids are recommended over a 6-month period, or tacrolimus-based therapy. The choice of therapy is dependent on the risk estimate. So in this algorithm, we evaluate risk, low risk, wait and see, moderate risk, wait and see, but you could consider rituximab or a calcineurin inhibitor. Try to avoid exposure to cyclophosphamide in this group of patients. High-risk patients would be rituximab, cyclophosphamide, or calcineurin inhibitor, plus or minus rituximab. And then in very high-risk patients, the one therapy that's been shown to benefit these patients in terms of maintenance of kidney function is cyclophosphamide. These are the risk categories, and they really demonstrate sort of what you would expect. Low-risk patients have a normal GFR, non-nephrotic proteinuria, normal albumin. Proteinuria in the moderate risk patients over 4 grams a day, normal GFR, and then sort of criteria by how they're responding to conservative therapy, all the way up to high-risk patients who have life-threatening nephrotic syndrome, a rapid deterioration of kidney function that's otherwise not explained. High low molecular weight proteinuria is also suggesting that the patients have risk towards progression. So this is a very nicely documented algorithm on how to treat primary membranous nephropathy. So with that, I think my time is just about up. And at the end of this session, I'll be happy to entertain questions with all the rest of the speakers. Thank you very much for your attention.